All right, opioid analgesics. Remember, these are things that work on the brain level. They come from opium. That is where these drugs originated, was from opium. They are very strong pain relievers. Now, we currently have more than just opium. I mean, you can't go to the store and say, hey, give me some opium, or hey, doctor, order me some opium. But that's where morphine comes from. So we've got the morphines and the Demerols and the codeines and the methadones. All of those are in the opioid classification. Opioids there are 3 different types of drugs within this classification: the agonists, the partial agonists, and the antagonists. Now, the agonists bind to the opioid pain receptor in the brain. They effectively block the pain receptor in the brain, thereby treating the pain, making the pain less. The partial agonists, some people call these agonist antagonists or mixed agonists. They also bind to the pain receptor in the brain, but they have a weaker response than the full agonist does. And then we've got the antagonists, which will bind to the pain receptor, but they reverse the action of the agonists. So if you give them an antagonist, it doesn't take the pain away. In fact, it counteracts any of the narcotics you've given them. There are times you want to do that. Somebody has too many opioid medications, too many agonist medications, you stop breathing if you got too many of them in there. So that's when we give them the antagonists to take away the effect of the agonists. But remember, they're going to have pain. Yeah, they've started breathing again because too many opioids, you stop breathing. So giving them these antagonists, they're going to start breathing again, but they're going to be having pain. And they wear off. If somebody has gotten a long-acting opioid and they've gotten too much of it, and then so we give them the antidote, which is an antagonist. The antagonist is going to wear off after a while, and then you still got all that opioid in your blood, and they can stop breathing again. So we have to be careful with that. Why do we use opioids? Mainly to alleviate moderate to severe pain. And we often use it in combination with other things, like NSAIDs and acetaminophen, and antidepressants and anticonvulsants and corticosteroids, steroids. They all have an effect of helping the opioids along. When do we not use it? Obviously, if they're allergic, we don't use it. Severe asthma or other respiratory insufficiency, if they've got that, we need to be very careful which drugs we pick, because some of these will throw them into an asthma attack, make them so they can't breathe again. We don't give it to people who have elevated intracranial pressure. What is that? Concussion is one of the common ones. There's other reasons for that. But they're going to be having a killer headache, but we don't want to give opioids because opioids messes up the brain level, and it also helps to stop some of the respiratory effort, so we're not going to be giving it to people who have intracranial pressure. And we also give it very cautiously in pregnancy, because anything you give the mom, you're giving the fetus. So we have to be very cautious with the use in pregnancy. Adverse effects. Go to box 10-1 in your text. Does a very nice job reviewing all of these. Some of the common ones: nausea and vomiting or GI upset. Respiratory depression and CNS depression are some of the most critical, because you give them too much of this drug, they die. So we need to be very careful with these drugs. Itching is common. I mean, it's not that common, but it's not unusual. And constipation. These drugs slow the entire body down. It depresses the central nervous system, and that includes the messages to the bowel for peristalsis. It slows peristalsis, so these people can have constipation if they're taking opioids for a long period of time. The two common antagonists are naloxone and naltrexone. Again, they reverse the actions of the narcotic. So if we've given them too much, we give them the antagonists. Some people live in chronic pain. We try not to have them live on opioids because of the number of complications with it, but sometimes that's the only thing you can do to treat their pain and make them comfortable. One of the problems is, after a while, they build up a tolerance, which means you need to give them more and more of the drug, higher and higher levels to achieve pain relief. Are we talking addiction here? Well, I want you to think of it as tolerance, because if you got chronic pain, you need the drugs, or you're not going to be able to function at all. You're going to have a terrible quality of life. We're not talking about somebody going out trying to get high. We're talking about somebody trying to be comfortable enough to live their life. Now, there's a physical dependence that can occur. That's where there's a physical adaptation to the body. And a physical dependence, you take away the drug, they have withdrawal symptoms. There's a psychological dependence, and that's the pattern of compulsive drug use that's characterized by craving the drug. That's the drug-seeking behaviors. They need that opioid for effects other than pain relief. This is the one that we're looking at when we talk about addiction. We're not looking at opioid tolerance or physical dependence. We're looking at the psychological dependence if we want to start talking about someone is addicted. Opioid tolerance and physical dependence are expected, and they're okay with long-term opioid treatment, and shouldn't be confused with psychological dependence. Someone who's got terrible pain, we're going to treat it. Yeah, they're going to get dependent on this drug. Yeah, they're going to get a tolerance, but we're treating pain. Misunderstanding all these terms leads to ineffective pain management and contributes to the problem of undertreatment. Physical dependence on opioids is seen when the opioid is abruptly discontinued, or when we give them an antagonist. What is all of this talking about? You stop taking the drug, or you block the way the drug works, and you go into a withdrawal. Some people call it withdrawal. Some people call it an abstinence syndrome. What are the signs and symptoms? Anxiety, irritability, chills, hot flashes, joint pain, lacrimentation. What is that? Tears. Tears coming out of the eyes. Rhinorrhea, what is that? That's runny nose. Diaphoresis, that's sweating. Nausea, vomiting, abdominal cramps, diarrhea, confusion. All of these are part of the withdrawal syndrome.